All right, good evening, everyone, and welcome to the Henry Schein Dental Academy webinar series. My name is Adam, and I'll be your moderator. Tonight, Dr. David Reznik is with us answering your questions as they relate to COVID-19 and dentistry. We did receive well over 100 questions from everyone, so thank you so much for submitting those for Dr. Reznik to review and answer. While we will be answering most questions asked, the Q&A is open during this webinar, and we will have time to answer additional questions during the webinar. Tonight's webinar is being recorded, and we'll send that out to everyone later this week. And lastly, there is no CE for this webinar. Dr. Reznik, always a pleasure to have you with us. I know you are very eager to answer some of these questions, and I do apologize for having you miss Monday Night Football.
Well, only for a portion. Well, thank you, Adam, for the introduction. I'm thrilled to be here. As opposed to being from possibly my work office, I'm actually at home for a change, so it's comfortable to be here with you all. And there we go. So I'm just putting the disclaimer up. These are my opinions and my thoughts, and let's get started with what I think is probably the most interesting question. According to my expertise, what is the most important piece of information I would like the audience to know? I have a few things to say. The first thing I would say is that I'm very proud of our profession for how well we've done with our infection control procedures, how well, after being shut down, that we have adjusted and how we're making a comeback. But the most important piece of information is that this is not over yet, that we have gone from bloodborne pathogen, basically, standard precautions, to now we're including airborne transmission precautions. So there has been a change in how we do our business and how we can successfully stay safe, keep our staff safe, and our people safe. So I think there's going to be a basic change in where we were to where we are, and we've already made the change. It's just how do we maintain this change, and let's see if we can get to some of those things by answering your questions. So the first area is on personal protective equipment, masks or respirators. Do we still need to wear N95 respirators and face shields? So the answer to that question is yes. If you're performing aerosol generating procedures, it is very important that you have a fit tested, sealed N95 on and wear either a face shield or some kind of eye protection like goggles. Wearing something like my readers so I can see the screen tonight, that is not eye protection. I prefer wearing a shield. There are shields now that work with loops, so it makes it easier, and I've been wearing a shield for quite decades at this point, so it's not that big an issue. There is an alternative that the CDC does offer. There are some people who cannot wear N95s. I have one staff person who has very bad asthma and has a very difficult time breathing through the N95. And so we have her wearing a face mask, not a respirator, and a shield. And that, according to the CDC, is fine. It's an alternative way of looking at PPE. Not the way I would prefer. I would prefer that everybody have on fit tested N95s, but you can wear a mask as long as you have your shield and the rest of your PPE on. What are the current requirements for N95? Let's see if I can make my picture go away. What are the current requirements for N95 respirators and face shields in dentistry? There was a period of time during when we were at our crisis stage of storage where we didn't have as much supply. We didn't have enough respirators as we needed. We didn't have enough gowns as we needed. I think it doesn't take much for us to go back and remember some of those difficult days. So there are conventional capacity settings that we have. There are contingency capacity and crisis. When we were in contingency, basically OSHA said you could determine whether or not, based on supply, you could fit test. It wasn't that it was not mandated, but you could skip it. Well, right now, fit testing is required once again. And so that is what needs to happen. Every time you change a brand, if you're using two different brands, both brands of your N95 respirators would need to be fit tested. And that's a very important process that we go through to make sure that they're working. As far as face shields, there's really no change. Like I said, there's multiple models out there. There's disposable models. Face shields, there isn't a shortage of. I have not worn an N95 at all, just level 3 surgical masks since before COVID or prior to COVID. Am I just lucky, or do level 3 masks work? Well, I think we've all been lucky for those of us who didn't get infected early on, but I will say, like I just mentioned, that you can wear a mask as opposed to the recommended N95. It's an alternative PPE that is accepted by the CDC. So if you're wearing a mask and a shield, then you're doing everything you need to be doing, you're fine. I still think that wearing a fit tested N95 for aerosol generating procedures is what we've been doing and what I would still recommend. The next question that pops up, it's my understanding we should not be wearing KN95s anymore. And that is for aerosol generating procedures. They were approved for emergency use only. Is that accurate? This is a great observation. Right now we are at conventional capacity, and OSHA is no longer accepting imported KN95. So we need to use our N95s. Now, do I let staff wear KN95s when they're around the clinic but not involved in aerosol generating procedures? If it makes them feel comfortable, more comfortable than a mask, I'm perfectly fine with that. But we're in clinic and we're seeing patients, no more KN95s, at least at our hospital system. But then it also depends on where you are with your supplies and what you need. For instance, under conventional capacity that the CDC talks about, we really don't need to, we really shouldn't be disinfecting our N95s. However, based in reality, there are certain places, especially hospitals that are being hard hit, that are still doing that. But we're wearing an N95. You can wear one in between each patient if that's what you want to do. I have staff that does not like to take them off that often. So they'll wear their fit tested N95 with a mask over it when they don't have their shield on. What evidence exists that common face masks really work with coronavirus and effectiveness of ASTM 3 masks, KN95, and N95? So there really are a lot of different studies. Let's go over what the ASTM mask 3 mask is. When you get a mask, they're either ASTM 1, 2, or 3. 3 is the highest level of fluid protection. It doesn't really protect you against aerosols, but it protects you some against aerosols, but not as well as an N95 would do. There was a large study that was done in Bangladesh with several 100,000 people. And what they did, and it was one of those, you wear a mask or you don't wear a mask. And they do now have a case controlled study where they show that face masks work. As far as N95s, we've had N95s in ORs for years. The respirators, they only let 5%. We have N95s that are used in construction work. We have those that are improved for surgical work. There are ones that we've used in dentistry for some time. So there are studies that show that these masks protect us. This is an airborne virus. And so you want to keep as much of it outside of you as possible. Are face masks mandatory for front desk staff at all times, even with plexiglass barriers? That depends on your program. I work in a hospital. If you are on site at any of the hospital locations, you must have on a face mask at all times, unless you were in your own private office or if you are eating lunch. And the reason that we still do this is, if you remember back to earlier in the pandemic, we were seeing outbreaks that were taking place at the front desk. They weren't happening in the clinical components of the offices. They were literally happening at the front desk amongst front staff members. So we do have a mandatory program. This is just, again, this is what I do, what our hospital's recommending, and what I would recommend for you, even with a plexiglass barrier. And we have one in my brand new sparkling clinic. We do have our staff only in a regular level 1 face mask. They don't need to be in an N95 or anything of that sort. If we're vaccinated and we're supposed to be immune to COVID-19, why are we still being reinfected? And why continue to mask up? No vaccine is 100% effective. So that's number one. So if you're not having 100% effectiveness, you're having closer to maybe 95% effectiveness or 95% effectiveness, there always are going to be breakthrough cases. And there was a study that we did looking in Georgia, my home state. I live in Atlanta, and I have to look at the numbers over here. They're looking at 4 million vaccinated people. There were 4,908 who tested positive. So that was a breakthrough rate of 0.12%. So a very small breakthrough rate. Of the number who were hospitalized, out of that 4 million number that I talked about earlier, there were 118 that were hospitalized, which was 0.00285%, and 24 regretfully passed away, and that was 0.00058%. So we do know that vaccines work. We do know that masking does help protect us. We do know that we can take steps to protect ourselves, but there are going to be breakthrough cases. And that's something that we're seeing. But my hospital, and as I said, I live in Georgia, we have had several, we've had over 100 patients in the hospital, up to 120 patients in the hospital with COVID over the last several weeks. 98% of those hospitalized have not been vaccinated. 100% of the people who passed were not vaccinated. So getting vaccinated is truly important, and adding that extra layer of protection, because not only do you want to protect yourself, but you want to protect those loved ones around you. Another way of explaining this is I work with a wonderful administrative director. She was taking her son, her husband, she and her husband were taking her son to college. They were all vaccinated, had been vaccinated. All three had breakthrough infections while they were on the other coast. So again, it's truly important that we take every step possible to protect ourselves and our loved ones, our patients, our staff. We don't want to be one of those few that ends up in a hospital. And even if you have a mild case of COVID, which is what these folks have who work, one of them works in the infectious disease program, they still felt like they were run over by a bus. So when you get the flu, for the most part, you don't go to the hospital, but when you are home, you do feel like that you've been hit by a bus. Well, COVID is getting hit by a bigger bus. It's basically the answer there. So let's go to patient communication. Should we continue to pre-screen patients with COVID-related questions? If so, what are the current questions that we should be asking? Honestly, we should be, according to the OSHA guidelines, the emergency temporary standard that we are somewhat under, we are still supposed to be pre-screening our patients. The questions really haven't changed. Are you running a fever over 100.4? Do you have shortness of breath? Have you lost smell and taste? Are you coughing a lot? Do you have a headache? Some of the symptoms with the Delta variant could be almost like allergies, as I've mentioned before, which could be congestion, a headache, a runny nose. And so those are the same kinds of questions that we've been asked before. Have you been around someone who tested positive for COVID, et cetera, et cetera? So yes, we should still be pre-screening our patients before they come in. Is that happening? For those who've heard me talk before, I've had some issues with my back. When I went to an appointment 4 weeks ago, nobody had on masks except me and the nurse and the physician who came in. Front desk staff, no masks on, no plexiglass, no anything. In the back, the same thing. When I asked about it, they said they were leaving it up to the client, the patient. When I went back 2 weeks later for the second follow-up, They were again wearing masks, but still not nearly as seriously, and no more pre-screening questions. So we need to be doing the right thing. It's a great way of pre-screening your patients, also confirming that they're coming in. And if you have vaccination status for them, some people, like what they did when they were testing me, they took a copy of my vaccination card so they wouldn't ask me if I'd been vaccinated kinds of questions. So yes, please still ask those questions. Please do the pre-screening. It's part of OSHA's emergency temporary standard. What is a good way to send out to patients who aren't coming in due to COVID? And that, I think, as we see the world get more normal, and we're seeing it now. If I happen to be a really big football fan, that's without saying. So I'm seeing these games that are full on Saturdays, these games that are full on Sundays. I'm praying that no one gets ill from this, but when people see a return to some level of normalcy, dental care for a significant portion of our population is normalcy. And instead of just seeing emergencies, we were doing for a while, and we do have to do some hunting to get our patients back. I mean, there are people who should be in recall that we had lost. And so we made targeted efforts to get the people that should have been in that missed appointment to come back into our program. So I think that you can't be healthy without oral health is always my number one message. It's a part of essential healthcare, according to the American Dental Association and every other dental association, and that we are safe in here. We're providing probably the safest environment that you could possibly go into. And that's how I honestly feel when I'm at work. I have more sinus concerns when I get home than I do when I'm in my clinic, because I have extraoral chair-side evacuation systems. Every room has a portable HEPA filtration unit. I have things called virus killers in the large areas. So, I mean, I went overboard, but I have an immunocompromised patient population, and my job is to make sure that I help them maintain and achieve optimal health. So I hope that sort of helps with those questions. So what about some live questions? What do we have, Adam?
All right, we've got some. For those of you that came in late or you missed my intro, we will be answering live questions throughout the presentation tonight, so feel free to use the Q&A section and we will answer these throughout. This one looks like it's around N95s. So I understand that fit tests are required for N95s. I'm having a hard time to get the same N95 respirators that I was fit tested for last year, though. How come we're at a conventional capacity currently?
And that is actually a great question. And I think that the point you're making is a legitimate question. Of course, I'm on a Henry Schein webinar, so I really can't talk about supply. I don't know what the supply that this particular extraordinarily large distributor has, but I can say that our hospital, we really aren't at conventional levels right now, and that we are reusing and disinfecting certain N95s. In my program, in the Oral Health Center, I actually don't reuse or don't disinfect, and didn't buy one of those little ovens or UV lamps to do that. So I think your question is right. I don't really think that we can say that we're in conventional capacity in dentistry. I think it's still hard to get certain supplies at this present time, not nearly as hard as it was a year ago. This is a really great question. So I think that we're somewhere between conventional and contingency in the real world, to be frankly honest. But if you're wearing a new kind of N95, please make sure that you have it fit tested. That is really important. And for some people who have medical reasons, there might be a reason they can't wear it. That's why we can go back to the mask plus shield. So I hope that helps.
Should I change my N95 after each patient?
And that is what is recommended, but that is not what my staff wants to do right now. I have some that want to change it in between patients, and that's fine, because you're not only worried about when an N95 gets wet, it loses its efficiency. It's not as good at stopping aerosol. Writing on an N95, not a good idea. And so we have to think that not only are we worried about getting the outside of an N95 respirator wet, but there's also wetness that comes from us talking. You know, when we talk, we have aerosol, we might have some spittle. And so changing when you're comfortable changing, as long as it stays dry and safe and has not been exposed to anything, I think you're fine. So you don't have to necessarily wear one each, even though that's a recommendation. What I've told my staff is I don't want them wearing one per day, that at a minimum you can wear, for those who want to keep it on, you can keep it on during the morning. And it's usually the younger staff who want to do that, and then put a new one on in the afternoon. But I have enough available that my staff could change one between each and every patient. That was an iffy question. I was an iffy answer, but the best I can do is be honest.
Is it okay to ask the vaccination status of our patients?
I think it's perfectly fine to ask the vaccination status of your patient. The question is it going to change how you treat the patient? We, for several decades now, HIV has been around for 40 years now, and we've sort of known a lot about it for several decades. We treat every patient as if they have a bloodborne pathogen who comes into our practice. So we put on gloves, we wash our hands, we put on gloves, we have on gowns, we have on some kind of mask and a shield. So we do all of the different steps that we would do. At this point, I'm sorry, Adam, I just lost my train of thought.
If you should ask patients if they're vaccinated.
So yeah, you can ask patients if they're vaccinated. I'm sorry, I did lose my train of thought. You can ask them if they're vaccinated, but is it going to be any different on how you treat? At this point, if the first question that came up, what's that one piece of information I would want everybody to know, is that we don't know who has a breakthrough case. We might ask the patient if they've been vaccinated. How do we know that the answer we're getting is the truth? Are we going to do antibody or antigen testing on everybody who comes in? Might be an idea, but are we going to turn away people based on COVID status, which really isn't an interesting concept per se. So you can ask the question, but I think we should treat everybody as if they have an airborne pathogen. So we really need to think about transmission-based precautions, wearing an N95 and a face shield, or if you can't wear an N95, wear a mask and a face shield. But you can ask the question. I think it's a good question. But remember, a little bit back around the beginning of July, you were told if you had been vaccinated, when you went indoors, you no longer had to wear a mask. So people who were vaccinated stopped wearing a mask. But this was an honor system, and there were a lot of people who weren't vaccinated who also weren't wearing a mask, and we ended up having another surge. So the question is, I trust my patients, I believe what they say, but I'm going to treat everybody as if they have an airborne pathogen right now.
All right, we are getting a lot of fantastic questions. I know most of them Dr. Reznik is going to answer coming up, so I'm not going to ask them right away. But there is one follow-up to asking if patients are vaccinated.
Sure.
And wouldn't you want to ask as part of a comprehensive medical history?
Would I want to ask that as a part of a comprehensive medical history? I think it's a great question to have on a medical history right now. I think whenever we see our patients, we should update the medical history. So asking, have they been vaccinated? When were they vaccinated? Those are important questions. But the point that I'm trying to make is, since we're asking these great questions, we're writing the information, will it impact the provision of dental care that we are providing? And I'm saying that in my estimation, and this is my infection prevention, sometimes a little bit over the top way of looking at safety, I would rather we be safe than sorry and treat everybody as if they have an airborne pathogen.
All right, let's keep going.
All righty, vaccines and vaccinations. Current vaccination update, current vaccine update. Will J&J become available again? J&J is available. It became available, I guess, last again in April. So we do have J&J vaccines available. Right now, though, there is no studies or no indication of whether there will be a booster for J&J there's nothing documented on that. But J&J is one of our 3 approved vaccines in the US. The other 2 are the mRNA vaccines that I'm sure we're very familiar with at this point. This was the hardest question I got, and I tried to do my best to find an answer. And let me see if I can. It was on the percentage of dentists, dental hygienists, and dental assistants that are fully vaccinated. Based on the estimates that I heard from the ADA's Health Policy Institute, there's over 90% or around 90% of dentists are vaccinated. From what I could tell from a separate report, it looked like there was more like 78 or so percent of hygienists. And regretfully, I couldn't get an answer in time for today about the percentage of dental assistants that are fully vaccinated. At my program, again, at a hospital, everybody who works within the Grady Health System. So these are Emory physicians and Morehouse physicians, Grady physicians and dentists, dental hygienists, nurses, all of the contractors who come in, all of the vendors who come in, all the people who are building out 2 other percentage parts of the building I'm in that are being renovated right now must be vaccinated by November 1. I have had 100% vaccination rate now for a period of time. So I think it's really important that we help people get vaccinated because it's very difficult getting dental assistants and hygienists hired right now, as I can attest to. Anybody want a dental hygiene job, have one open, just kidding. Actually, I do. So I think that I don't have all that information, but we need to encourage our staff not to boss. What happened with my folks was when the talk of the vaccines was out there, I gave them a simple sticky pad. And I said, I want a Y if yes, an N if no, if you would take the vaccine when it comes out. I work in an infectious disease program and I was horrified that 67% had said no at that point. What I ended up doing over a course of weeks was just continue to do what I'm doing now, which was to provide some information, to try to answer some questions. Some people truly wanted to see how others would do. So I got vaccinated the same day as my oldest staff member got vaccinated. We had one holdout who just needed to get approval from a cardiologist. And so we really did do a good job of getting everyone vaccinated. And I would hope that as healthcare providers, if you're able to get vaccinated, that you should. Can we require our staff to be vaccinated? I think that depends on what state you live in. I live in an at-will work state. So if you're in a private practice, you can require your staff to be vaccinated. What about get vaccinated or risk losing your job? I don't think that type of approach really works. This is just me. I think that's a little bit hard, but that's what's happening at the health system right now. And that's what's one of the big issues that we're seeing with hospitals. Just to give you an idea a little bit outside our scope, that our hospital was afraid to make this mandate because if other hospital systems didn't, the nurses in our hospital who did not want to be vaccinated would then leave and go get another really high-paying nursing job at another hospital. But the system in Atlanta is trying to be coordinated so we don't have that kind of instability in care. Our health system, which has been on our hospital has been on diversion for, I think at this point, well over 24 hours again, and we are the level 1 trauma center. So I don't know about forcing people to say, let's get back, vaccinated or lose your job, but that can be a reality. And it truly does depend on where you live. And if you're in a big corporation where there could be potential suits or whatever, there's legal issues that I am not qualified to answer. We have multiple staff members and patients with high blood pressure. It is related to the vaccine working, and is it related to the vaccine working and constantly fighting the virus? Actually, hypertension is very common in my patient population, which is why we do take blood pressures quite frequently in our program. It's not necessarily related to the vaccine working. What I think you're getting confused with is when you don't feel good the day after that second shot, that is a sign that your vaccine is working, that you're having a reaction. But high blood pressure, no, I would think that that's related to other factors, diet, coronary artery disease, et cetera, et cetera. Are there any potential risks to having the seasonal flu vaccine and a COVID booster at the same time? Another great question. And the answer is there aren't any potential risks of having the flu vaccine and a COVID third shot at the same time once it does become available. As a matter of fact, Moderna is presently working on a flu vaccine booster in the same mRNA shot. So there is no issues with getting them. I actually, what did I get? I got a pneumonia shot and the shingles shot at the same time. To this point, of all of the vaccinations I've had, and I don't want to scare you away from getting shingles vaccine, that was the hardest for me. That actually did knock me down for a day, whereas the COVID vaccine did not. But it's perfectly fine for you to get both of the shots at the same time. When will the Gentlefield be eligible for the third vaccine dose? Let's answer that question. As far as rapid test goes, you can buy one from Henry Schein. You can set up a system in Henry Schein. They have that available. There are tests. There are 3 different kinds of over-the-counter tests that are available now. So those tests are available. But unless the person is doing a self-test, if you are testing somebody, you have to have a CLIA waiver. Whenever you're dealing with body fluids or doing a diagnosis, you must have a CLIA waiver. But if you want somebody to self-test in your office, they can do that. And these are over-the-counter tests and not very expensive. Or you can set up something with this company, because Henry Schein, because they are selling COVID tests now. So when will become eligible for the third vaccine dose? Well, the first thing we need to know is when are they going to approve the third vaccine dose for non-immunocompromised people. Presently, about 2.7% or whatever of the population is considered severely enough immunocompromised to go ahead and get that third shot. But for the general population, it is not available yet. And so the CDC and APIC are meeting now, and they're going over the data, but this has become really somewhat, in an odd way, controversial. There are some people who are very against giving the third shot now because they think we still have enough immunity and that we need to wait on it. There's others who think we need to build it up now because some of the immunity is waning. But if you look at the people who are being hospitalized, if you look at the people who are regretfully dying from this disease, they have not been vaccinated. So we're seeing that the vaccines are holding up. There are 2 main things that they do. They prevent serious illness and they prevent death. That's what they're basically guaranteed to do. They're not going to they're not going to stop a breakthrough infection, which is why they will for the most part, why we really need to continue our masking and in public and indoor settings. Please discuss procedures to follow if a staff member has symptoms of COVID. Well, the first thing is, if you are sick, you need to stay home. And this is a really important message. And I've seen people come to work sick for decades now. They don't want to miss a paycheck. They don't want to have to reschedule that case. They don't want to, whatever the reason is. If you are sick, you need to stay home. You can get an over-the-counter COVID test to see if it's COVID. You can go to your physician, do a telemedicine visit, but don't come into the office if you have symptoms of COVID. Should dental offices mandate the vaccine for staff? That's a personal choice. There is no legal mandate that people must be vaccinated, but if you are a business owner and that's what you want for your office, that is perfectly fine. If you are in a public health environment like I am, where people from above my level are telling me that this has to happen, then it's fine to mandate the vaccine for staff. And I have not seen any legal challenges to it, at least in a large health system. The last question on here is, my hygienist had COVID. I'm sorry to hear that. Quarantine, recovered, and refuses to get the vaccine or wear an N95 mask. So here's my first thing. One, she has COVID, so there is a certain level of immunity that's there. If she were to get vaccinated after having COVID, she would basically have hybrid protection, which means, in a nice way of putting it, super protection. So she might be able to go out without having a mask on in public, in a grocery store or in a concert venue or whatever. But this individual had COVID, she quarantined, she got better and doesn't want to get a vaccine or wear an N95. Remember, there's an alternative to N95s as long as you wear the rest of the PPE, meaning you can wear a face mask as opposed to a respirator with a shield, with your gown, with your gloves. And don't forget the most important component of this. Don't forget that before you put on gloves and take them off, hand sanitation. That's always important. The number one way that people get health-acquired infections is from not washing your hands. So if a patient asks, has everyone been vaccinated? How do I respond? My own personal feeling is it's really truly not their business, but if they are concerned, what I would say in that case is everybody has antibodies. And that way you've answered the question and they can make of it what they would like. I know that people are asking that question. I know I work in a program which I would not see that question being asked very often. I have not been asked that question because I think they all know that. But if somebody wants to know the vaccination status, again, that's your choice. If somebody asks, in this case, where somebody has some antibodies, has everyone been vaccinated? I would answer the question the way that I would answer it, which is they would have antibodies to it. So variants and boosters. Let's see what we have here. Are there any new variants we should be concerned about today on the 13th at some point after 8 p.m.? The answer is no. The Delta, we were concerned about the Mu variant, which was seen in Peru, making up a significant percentage of cases. But when it comes to a battle for superiority, who is going to live and who is going to thrive and who is not, Delta by far has a much higher replication level. And even though Mu might be able to escape some of the vaccine and maybe some of the monoclonal antibody treatments that are out there, its replication factor isn't strong enough for it to be able to overtake Delta. So right now we're dealing with the worst that we've had, and we need to keep an eye out for that. I mean, I think that's the most important thing I can say. Some people, I just think that we just need to keep an eye on it. And the main reason is we have maybe a bit over half of the adult population in the United States presently fully vaccinated. And so we have a lot of where the virus can still replicate, where you can get, and the more the virus replicates, that's going to throw out some mutants, some that live, some variants don't live. So there is the chance, but when you think about it globally, where did Delta come from initially? And I know we're trying to get away from saying what country, but it started in India and it caused a significant amount of death and dying and illness in the country of India, where so many people were impacted. We knew that months before it got here. So I think we need to keep our eye out on what's going on globally, realizing that a significant portion of the globe has not yet been vaccinated. So we probably will see more variants. Hopefully the worst is the one that we're seeing right now. How contagious is the Delta variant from an aerosol? Well, it depends on how you relate it to the first variant. The first initial one, the first variant was more infectious than that, and this one's by far more infectious than the previous. So it is, the Delta variant is quite, it's quite likely to be transmitted still in a community setting, like a restaurant, but those who are vaccinated have protection. So there was a period of time, and I'm sort of the one that's controlled on what I'll do, where I did go to a restaurant for a birthday because the level of our community spread was low. And I think that's something that you need to be aware of. You need to be able to know what your community spread level is. Right now in Georgia, Alabama, Mississippi, it's very high. I doubt that it's all that high in Massachusetts. I have a feeling that my work sister, Helene Bednarsh, is on, and she might know better than I would. But you'd really, if you know what your community spread is, and you basically have an idea. On surface contamination, one of the things that we were so concerned with at the beginning, even from the ADA recommendations, was fomite contamination. We removed all of the paper and magazines from our offices. We put hand sanitizer out, which we still do have out, and napkins and tissues and the trash can. Contagion from a surface contaminant is minimal, especially if you have good hand hygiene. So my concern would be an aerosol, but if we can get everybody vaccinated, wearing masks appropriately, then I would be comfortable going to a restaurant. Does a third booster shot significantly improve immunity? A great question that the CDC is trying to answer right now. And we have a little bit of a battle, I would guess, going on amongst scientists, which is not abnormal. I mean, that's where science comes from, is difference of opinion and seeing who is right. Some people at this point are saying, yes, it will increase rates and it will improve immunity, or we don't know. So for people who have waning immunity, for people who are older, even older than me, then they might have waning immunity. And I think that's what the CDC will be discussing. When would I suggest the third shot? When it is FDA approved. And right now, the only one that has been approved, at least for immunocompromised patients, is the Pfizer vaccine. Moderna's booster has not been approved, and I don't know of a booster for J&J. And presently, they're not recommending mixing the mRNA vaccines, even though we've seen some information from Europe that is a bit more positive. So the third booster, when it is FDA approved, will have the evidence in hand to say, yes, the population needs to get this booster. And when I suggest that we get it, would be right now, they're looking at 8 months past your second dose. Let's see what the research says and what the CDC comes up with. So that's about as well as I can answer that one. We're going to play Stump the Dentist now. Adam, what questions might we have?
Stump the dentist we shall.
I'm sure.
No,
this is not the easiest topic here.
We've got lots of questions, so we'll try and get through them quickly here. I know you've answered this one on past sessions. My assistant is pregnant. Is the vaccine safe for the baby?
Yes, we definitely want people who are trying to get pregnant, people who are pregnant, to get vaccinated. What we don't want to have is mother-to-child transmission, which we've seen in a few cases. The American College of OBGYN is 100% supportive of this, as are all the other medical bodies. So please do. It does not cause infertility. Nicki Minaj, someone from not my generation, put on a story on social media that some friend, I don't know if it was a relative or whatever, were going to get married. He got the vaccine and it caused testicular swelling, which ended up for some reason ruining them. They didn't get married. That is just malarkey. So if you are trying to have a child, you are with child, you are breastfeeding, you can be vaccinated. Adam, did you fall asleep? Oh, there you go.
Nope, I'm still here. Haven't really talked about quarantine lately. So, if a dental assistant or a staff member goes out of state for travel, what are your recommendations on should they quarantine, should they not?
I wouldn't recommend based on travel, no. That was an older kind of, have you been exposed to somebody? Have you been exposed to someone who has COVID? So what does that mean? That means a total of 15 minutes around that person within 24 hours. So it's not just a 15-minute conversation. It could be 5 minutes here, 5 minutes there, and 5 minutes there, or however you want to do that. Another brain moment here. Help me with repeating the question again. I'm sorry.
That's a good question. I had a brain lapse myself. Quarantining.
So now if you've been exposed, You can stay out 7 days if you have a negative test on day 5. You can't take the test before day 5, but if you have a negative test on day 5, or you stay out 10 days, whether you've had a test or not. So for instance, I was telling you all about my colleague who was taking her child to college, and she ended up getting a mild breakthrough case of COVID, which she would not describe as being mild. She was out for 10 days because we knew that she was going to test positive because she already had. I hope that answers.
All right, we are running short on time, so let's keep going forward.
Okay, I'll try to give shorter answers. Are there guidelines for staff who have had COVID and recovered, who are vaccinated and then exposed to COVID positive people? I think I just actually answered that question. So I think I could probably skip that. If they have been exposed, they can be 7 days if they have a test after 5, and if they don't have a test, it's 10 days. I'm trying to make sense of the CDC guidelines about exposures and positive tests with vaccinated and non-vaccinated. So the CDC has just actually released some new combined guidelines that are literally getting dentistry into the full CDC status. So it's whether medical, dental, et cetera, they're all going to be one set of guidelines. And so basically, again, as I've just touched on it, the exposure really depends on what you have tested 5 days later or just 10 days. So the CDC guidelines sometimes seem complicated, but literally just need to know a few things there. And hopefully I got them across for you. Any idea if we'll eventually get a dual guidance from CDC about vaccinated versus unvaccinated patients? This goes to what I thought was the most important point that I wanted to share today, is that we need to look until further notice, until we get past this pandemic, which could be a little bit longer than we thought. We need to treat every patient as if they have an airborne pathogen. So if you're not wearing the N95 and you're doing the alternative CDC, wearing a mask and a shield, how different is that from what you were doing before COVID? So hopefully that will be helpful, but treat every patient as if they have COVID at this point. What are the steps required or mandated to ensure staff and patient safety at this time? Make sure that you have a plan in place, that you know what's going to happen when there is an exposure. Make sure that you're providing the appropriate PPE to make sure that the staff feels comfortable and that your patients feel comfortable. So there are certain things that came out of the emergency temporary standard. We are exempt from most of it. However, there are certain parts that we do have to follow, which is the pre-appointment screening, which we've talked about. Everyone must be screened prior to entry, and that's something that's not happening as much. You can do it at the front desk, but you need to be screened upon entry. Dental practices must have a COVID-19 plan in place, and hopefully you have it in place by now. But you always have to remember that state and local authorities, especially state authorities, can be even more intense than what the federal OSHA standards are. Air management. How much of a concern are aerosols that are suspended in the air when attending a dental appointment, cleaning, or restorative? As I mentioned earlier, it really depends on, one, your ventilation. I am not an HVAC expert. I know how to turn it on and off, and we're in a new clinic and we still can't get the temp right. And so the bottom line is, if you have your equipment in place, you have your HEPA filtration in place with a MER value of 13 or greater, you have good air exchange, you have like I said, I use the extra oral evacuation system. I'm not concerned about it whatsoever, but I do have a mask in the clinical areas. I do not let people into the clinic areas without a mask on, period. This is a more interesting question for me. Should dental, they're all interesting questions, I should say, but should dental hygienists use an ultrasound? There are colleagues of mine who are very strongly opposed to using an ultrasound. And I understand that. It does create a mess. It does create an aerosol. However, I didn't want, working in HIV all these years, when I've seen the exposures on my hygiene staff, it's from using too much force. I also have had a wrist surgical procedure at some point in my dental career. I didn't want to ruin the career of the wonderful hygienists that have worked and are working in our field, or working especially in my program. So yes, we have extra tools just for our hygienists so they can use the ultrasonic. So again, I talk about the chairside extraoral evacuators that we have. We have the oral shields that we use. We have the HEPA filtration that we use. We have the big room virus killers that we use. So I am all for dental hygienists using the ultrasonic if they have the appropriate equipment to keep themselves and other members of the staff safe. If you don't have the equipment and you're just planning on using slow speed suction and no high speed evacuation, which gets rid of 90%, then don't use the ultrasonic. And one of the ways we look, and I ask my staff to check after every time they use it, what showed up on the shield? Is there any splatter on the shield? Because if there's splatter, there's aerosol. And so one of the things that we don't want to have is that. Should patients be tested for COVID-19 prior to aerosol generating procedures, regardless of vaccination status during the pandemic? Again, my philosophy is a bit different. My philosophy is that we need to treat everybody that is healthy in our practice. We want our patients who are sick to stay home, everybody as if they have an airborne pathogen at the present time. So I think testing is a great idea. It will let people know if they have been infected, and they can take steps at home to protect their family and themselves, that it's not going to impact, even though the recommendations say avoid aerosol generating procedures and someone's suspected. If someone is suspected to have COVID, then they're ill and they don't need to be in the office. If someone is in your office and not running a fever, doesn't have any symptoms, then we really don't know who has and who doesn't, because 50% of the people who present are going to have either asymptomatic disease and never show symptoms, like the child of my friend who went to California, or they're going to have pre-symptomatic disease and they'll develop the symptoms after they leave. Live questions. I went faster that time, Adam.
Help me out here. Do we have any slides coming up, or is that the end? Yep.
Oh, this could be it.
All right, so let's get to it. How is your knowledge on pre-procedural mouth rinses?
Oh, we use a pre-procedural mouth rinse on all of our patients for all of our procedures. We have been using, I try to stay away from brands. So we've been using a diluted hydrogen peroxide mouth rinse now. We do it for 1 minute. I have never had a cuspidor in a program that I started, so I don't believe in spitting, and I really don't believe in spitting during an airborne pathogen, so we suction it out for them. So we do a pre-procedure rinse for every patient. There are some good data on other types of rinses that work, so yes, I'm a big fan and do believe in that.
Right. Back to, let's see, should you cancel a patient if they have COVID symptoms but have not had a test?
Yes. I would not treat someone that was sick unless they were running a fever based on a dental abscess. Right now, people who are sick should stay home. And that is really key, especially when we're talking about preventive or elective care. If it's an emergency and they come in, we're protected, we can treat. But if people are sick, whether you're a staff person, whether you're the owner of the practice or a dental hygienist, dental assistant, office manager, if you are sick, please stay home and don't spread it amongst the patients and staff members that you will come with.
Can I ask unvaccinated patients to provide a recent COVID test result before coming in?
You can ask politely anything that you would like to ask. They can show you a recent COVID test. Emory was doing that for some time. Before you go into a hospital, you have to have a negative COVID test 72 hours in advance. That is up to your practice's choice. If they're vaccinated, you could ask for that as well. So those things are fine. But remember, the overarching infection prevention principle of the day is treat everyone the same and pretend that everyone has an asymptomatic case.
Is it a HIPAA violation to tell patients our staff is vaccinated? We've run into this issue with an office we refer to not willing to disclose that information.
It's a protected, it's not a HIPAA. HIPAA, it's a protected health information question. And in my opinion, I don't think it is an appropriate question, to be frankly honest, unless you're working in a really large kind of facility. I think that, I don't know. I think that knowing someone's status isn't going to impact how I refer somebody. If they ask like that question about the hygienist who had COVID, didn't want to wear the N95 and didn't want to get vaccinated, what was the answer? Well, she has antibodies. And so I would say either yes, the vast majority, or if you're in a practice where no one wants to get vaccinated, be honest with them. I mean, if you choose not to get vaccinated, then that's your choice to tell them. If you choose to have your staff try to stay as healthy as possible and get them to the place where we're getting vaccinated without any kind of mandate, because try to avoid those kinds of things, then do the education method. If it does come down to it, like we've done at our hospital, we first started with directors and above, and then we went to our regular staff that we put a date where you had to get it done. So those questions are really up to the individual practice or practice owners and et cetera.
Let's see, follow up to the should we change our N95 after every patient? Should we change our gowns after every patient?
Yes. Yes. If there's
And
aerosol that's in the air, we definitely recommend changing the gown after every patient. If it's it's a situation where you have on a lab coat and you're doing maybe removable, or you're seating a crown and there's really no aerosol generated, please make sure you leave the lab coat in the dirty room. In the room, don't take it into like an office space or walk around with it and go outside with it or whatever. But we recommend changing the lab gown after every patient, yes.
do you know of any guidance or just any recommendations on how soon after you see a patient, how long you should wait until you see another patient in that same?
Oh, there was that old 15-minute guideline that you wanted the aerosol to settle before you could go to see your next patient. Well, it takes, depending on your wet time for your room and how fast your assistants are, by the time we turn over a room, and if you have your air purification systems, your HEPA filtration systems, you've taken the steps you can, that 15-minute time really doesn't mean anything to me anymore. It takes enough time just to turn the room over and get reset up for the next patient. If you have a larger facility, you're not using all the chairs at the present time, then you could go to another room. But literally, I have so many devices in the program. The whole concept is that we could return to normal levels, normal volumes of care, and that's where we are today. We're at normal volumes of care. We still have some patients who are missing. We're getting them back in, but we're back to the level we were pre-COVID.
Have we stumped you yet?
Oh, a lot of these questions are stumping questions. I mean, they're very good questions because some of them are really up to individual practices and individual beliefs. I would rather be on the safe side. I want my staff vaccinated. I want them masked at all times. I want them to do everything possible to ensure, as OSAP's model is, to ensure the safest dental visit. That's my responsibility. It's my responsibility to make sure that my staff and my residents and my patients are just as healthy when they get to work as when they leave, that nothing happens that's going to put them at risk in the office space. So as you can tell, infection prevention is a big part of my world. And I'm very glad that I get to work with the wonderful people at Henry Schein and OSAP to help me through these, because I don't know all these questions. I have to do a lot of homework.
All right, well, that brings us to our hour. So I do apologize if we did not get to answer everyone's questions, as I know for a fact we did not. But of course, if you have any pressing questions that we did not answer, please do feel free to email us at webinars@henryschein.com. And we will, of course, work with Dr. Reznik to get your question answered. As I said at the beginning, tonight's webinar was recorded, so we will get that out to everyone hopefully later this week. Dr. Reznik, as always, thank you so much for your efforts and knowledge and expertise and humor and whatever else you want to tack onto that.
It was an absolute pleasure. I hope that everybody survived the hour. I really appreciate it because I need to know what you all are worried about. When we do these monthly updates now, it really helps me to know what the concerns of the community are. And so I greatly appreciate these live sessions, although a tad stressful. So thank you, Adam.
A little stress is good.
Oh,
Like Dr. Reznik said, we do host these monthly. If you are new to this series, it's usually the third Friday of every month. We do an afternoon session, and then we will throw in these live Q&As from time to time. So with that, I think we are good to go. Thank you, everyone, especially on the East Coast, for staying up late with us tonight, and have a great night.
thank you. Good night.